My name is Ghosh, and I'm one of the consultants here at the Eye Hospital. And thank you very much for asking me to talk here. This stems from is my subspecialty interest is oculoplastics, and part of it is watery eyes. So I run a watery eye clinic every alternate Friday here, and believe me, half of them are actually mismanaged dry eye conditions because they present with watery eyes as well. So one of the pearls for you to take away from here is if you see watery eyes, then there might be an element of dry eyes there. So just a little bit of an overview. Everybody does a test in the end. So I'll start off with a small test for you all. So what conditions do you see with red eyes in the community? Yeah. Anything else? Okay. Yeah. Anything else? Okay. So whatever you have said, they're all here. And believe me, lumps and bumps and cataracts can also cause red eyes, because if you've got a nasty lump and a bump, that can cause red eyes. And cataracts, if they're leaking or if they're causing uveitis, that can cause red eyes as well. So just a few photographs to take you through. What's this? If you can see the lid margins, blepharitis, that's right. What's this? So doesn't have the typical discharge, but it's more watery. So this is more likely to be a viral conjunctivitis. So this is dry eyes, because see, the whole idea of showing you these photographs is they all look the same. So I know your problem. So what's this? Yeah, can we? Okay. See this bit, the reflection from the tear meniscus, that's actually quite high. You wouldn't normally see this. So that's actually a watery eye. What's this? So the idea of showing this is when you see somebody come in with this, that's a corneal ulcer or keratitis. Always lift the eyelid and turn it, because there might be a subtarsal foreign body causing that. And that? So that's a dendritic ulcer, and that's more likely to be a bacterial one, because this is much more severe. What's that? Yep. So that's the hypopion, that's an angry red eye, and you could get a similar picture if you see that after a cataract surgery. That's endophthalmitis. So that needs to be referred straight away. And that? And that. So these are different grades of cataracts. And this one is my favorite. What's that? Yeah, and what's that? So that's a chalazion, and that's a stye. And we always get, everything is a stye. So so stye is actually a folliculitis, whereas chalazion is a swelling of the meibomian gland. Yeah? Again, if you don't take anything away from this talk, remember that. Okay, so I've already said that as the preamble, that 50% of what I see is actually dry eyes, which hasn't been managed properly. So it's a huge subject, and it's not possible to cover it in 20 minutes. So I'll try to give you an overview and some pearls to help you diagnose and probably manage them better. So just a quick run through of the anatomy. The lacrimal gland is present on the outer side of the socket, whereas the sac or the drainage system is on the inner side of the socket. So if you see any swellings on the outer side, that's from the lacrimal gland system, whereas if there is a swelling there and if there is mucopurulent discharge from the inner side, then that's from the drainage system. So what does the eyes do? The blink is very important to us because it spreads the tears and it helps protect against infections. It washes away any sort of foreign bodies that come into the eye. And it is rich with glands which secrete the different components of tears. So it comprises of many structures. Without going into the details, the corneal epithelium, its integrity, the tear film, and the general integrity of the ocular surface is very important, which is affected by dry eye conditions. So the different glands that constitute tears is the lacrimal gland, the meibomian glands which are on the lid margin, and the goblet cells on the conjunctiva which produce mucin. So the tear that you see is actually a quite complex structure which is made up, is simplified into 3 layers. The mucus layer which holds it to the surface of the eye. Then there is an aqueous layer or the watery component which is not really water but it has got lots of minerals in it as well, which is secreted from the lacrimal gland. And the final layer is secreted from the lid margin, which is the oily layer which prevents it from evaporating. And so any of these being affected will cause dry eyes. So that is how it looks. This is the biggest or the thickest layer, which is the aqueous layer. That's the oily layer on top. And this is the mucus layer which holds it to the surface. So as I said, it cleans, it supports the cornea, and it takes the oxygen supply into the cornea because it doesn't have any vascular supply. And it keeps the eye comfortable. So just an idea how a healthy tear film looks like, and when it breaks down, it just is totally anatomically wrong. So what are the different types of dry eye disease? Broadly, it's classified into aqueous deficient, which means that the watery component is deficient, and the evaporative, which means that it's there, but it's not staying in the eye for long. And the reason for that is that the oily layer is deficient and it's not allowing it to stay in the eye for long. And we'll come to that causes in a minute. So aqueous deficient most of the time is because of the Sjogren's type of diseases where they will also complain of, what other symptoms do they complain of? Dry eyes and dry mouth mostly, but they can complain of dryness wherever there is mucus surface. And the non-Sjogren's type is where the lacrimal gland itself has got a problem. So the bulk of the tears is not present. Whereas in the evaporative type, which is this group, so this is mainly due to the meibomian glands not functioning properly. So if somebody has got blepharitis, they will suffer with these. If somebody has severe posterior lid margin disease, they will suffer with this. And then there is vitamin A deficiency, which we don't see in this country that much. And another big offender is people on eye drops which have preservatives. So that is becoming increasingly known as a big problem. So as I said, there are 3 types of mainly broad dry eye conditions. And the kinetic disorders obviously is if the tears are being impeded. So if somebody has got a blocked tear duct, then they can have problems as well. Any questions so far? No? Okay, so what do they present with? How do we diagnose them? There are tests, and we will come to that in a minute, but their symptoms are very characteristic. And the first thing that they come and tell us is, I've got grit in the eye. And if somebody says that, they've got dry eyes. Whether it's severe, moderate, or mild, that comes next. But the other symptom, which is becoming increasingly popular, is asthenopia. Do you know what asthenopia is? This is a sense of tiredness of the eyes. And this is because if the eyes are dry, a lot of people nowadays are dependent on their computer screens. And when you're looking at computer screens for long hours, you stop blinking. There is a very good video on YouTube. Go and have a look. Normally, we blink 12 to 14 times in a minute. There is a guy who's watching television, and he blinks once in a minute. So you can imagine what happens to the tear film. And that's so important. The more severe ones will present with burning sensation, stinging sensation, and in extreme cases, they'll present with a red eye, which I've already shown you. And if they suffer from disorders like rheumatoid arthritis and Sjogren's syndrome, they're bound to have some symptoms associated with dry eyes. The other thing which we need to be careful about is contact lens wearers. And as I said earlier on, glaucoma patients, because they are on so many drops, and most of the drops still have preservatives in it, they cause problems with the tear film. So another common term that we use is tear film dysfunction. So how can we diagnose dry eyes? So these are the common tests that we do. So lacrimal river width, I'll show you each of these in a minute, which I showed you in one of the first photographs where the actual tear meniscus is higher if they have a problem. The Schirmer test actually measures the amount of tears being secreted into the eye. The tear breakup time is valuable to assess if somebody has got evaporative eye disease. And again, I'll show you how to do that. Staining shows us if the corneal epithelium is intact or if there is drying anywhere. And the tear lab, this is the latest toy we have. It's complicated, and essentially it measures the osmolarity of the tears, which gives us an idea whether it's good tear or bad tear. So Schirmer's test, but is tear breakup time. And it's based on, the tear breakup time is obviously based on the fact that there is a time span for which the tear film should stay in the eye. And if you ask the patient to keep the eye open and it breaks up before that, that means it's unstable. So that's the Schirmer's test, which if you see, these are the two papers that we put in. Some do it with drops, some do it without the drops, and the measurements are different. Normally, you would get 10 to 15 within 2 minutes. And in some, it doesn't even take 2 minutes to get to that stage. Tear breakup time, as I said, so what we do is we put a fluorescein and ask them to blink and then hold. And if you see these black spots appearing within 10 seconds, that means they have an unstable tear film. Now, the point of me showing all this is you can do this in your practice, and you can actually make a diagnosis of these. So they don't then need to be referred on to the ophthalmologist. It saves you money, and it saves us time. Because ultimately, they will be sent back to you for looking after them. And it's very easy to diagnose this. We are more than happy to deal with the more complex ones, which we will come to in a minute. But this is a very simple test. All you need is a filter, which you can put it on the top of a torch, which is an ultraviolet filter, and a drop of fluorescein. That's all you need. So that's the staining. Again, you put fluorescein in, and as you can see, the areas which are dry will take it up because the epithelium is not wet properly. And then you can actually make a drawing of the areas. And that's the lacrimal river width. That's, as you see, that normally you should not be able to see this. And that's the toy. So that brings us to meibomian gland dysfunction, which means essentially if you see patients who are presenting who's saying that the lids are really red, and at the margin of the lid you see these kind of meibomian gland openings are swollen, they have an inflammation, an active inflammation of the meibomian glands. And you have to treat that. If you just give them artificial teardrops and send them away, they will not get better, and they'll keep coming back. So the theory behind this is that the meibomian glands secrete an oily secretion, and there are bugs at the root of the eyelashes as well, which secrete a toxin. It sets up an inflammatory reaction, and that just compounds the problem. So you have to treat the meibomitis or the inflammation of the glands, and then you also have to treat the tear film dysfunction. So I'm sure you see this every day, that people come in with a lid margin like that. A lot of people who have rosacea would present like that because they are more prone. And so you will see this, the meibomian gland opening, sometimes the atrophy due to chronic inflammation. Can you see? Am I in your way? Okay. And as you can see, notching of the lid is caused by because the meibomian gland is dead, so it's not functioning. So because the top layer of the tear is deficient, so the patients would complain that they do not get relief from whatever drops they put in. So they present with red eyes as a result. The next group of disorders which cause problems is ocular surface disease. So if I showed you this, what is this? It looks like ichthyosis, doesn't it? But this particular one was actually pemphigoid. So when you've got something like this, as you can see, the lids are ectropic because they're being pulled down by the skin condition. The whole surface is ulcerated. So that's going to have a definite effect on the corneal surface as well. So to treat the meibomian glands, 3 things, again, you can do from primary care. Hot fomentation, which is dry fomentation. So flannel, ask them to warm it up on the radiators. That's the right temperature. Ask them to hold it over the eye with a bit of pressure, and that liquefies the secretions there so that they can then discharge and they don't get clogged up. Because if they get clogged up, then you get the chalazions, which is another problem. And the second thing is lid toilet. Again, you will hear different stories, tea tree oil, sodium bicarbonate, and lots. You will hear the latest advice on the NHS website is don't use baby shampoo. I still feel that if you get a baby shampoo which does not have any essences in them or the flavoring material and all that, they're still the best. It's the way you do the lid toilet that is important. And what I always say is take an egg cup full of water, 2 to 3 drops of baby shampoo, take a cotton bud, dip in that solution, and use that as if you're putting makeup on your eyelashes. And that way you're actually scrubbing the eyelid, which is what you need, and not just putting the makeup on. So essentially you're getting rid of the toxins, and that helps with the inflammation. And the third thing is they need a course of doxycycline or limecycline depending upon what they can tolerate, because doxycycline, some people have stomach upsets. Sure. The cleaning, depending upon how severe it is, even once a day in the morning is good enough. Sometimes you have to do it twice. Now, in terms of local treatment, there is another element to dry eyes, which is inflammation. If the corneal surface is inflamed, like I showed you in ichthyosis or Stevens-Johnson's type disorders, then you have to treat the inflammation, because otherwise the tear film is not going to get stable. And the only drop available so far is cyclosporin drops, which you may have heard about. So if it is going into that domain, then obviously the patients need to be in the hospital. This is in advanced cases where you might have to reconstruct the corneal surface altogether. But again, there are simpler things that we do, which is like putting in a punctal plug, which is a piece of plastic, which blocks the tear duct openings and thereby retains the natural tears that are being secreted. Because no matter how many types of eye drops we have in the market, nothing comes even close to your natural eye drops. So if you can have that in the eye, patients get instantaneous relief. The second step further, if though that's not helping, is you can actually have inserts put in which are continuous release and secretes tears. You can use eye drops, which stimulates the eye glands, the tear glands to secrete more tears. Now, whatever I'm saying is based on an international dry eye disease workshop. They last met November last year, and all the classifications, all the treatment modalities are based on their recommendations. And this is just sort of like an aide-memoire of what you should be doing in your practice. And as I said, for mild to moderate disease, just eye drops are good enough, whereas moderate to severe, they need more intensive management. And for the really severe ones, they need sometimes even immunosuppression, amongst other things. So this is just a simple treatment chart to show you how to manage. And I thought this was quite a good one because there's an overlap of all the different types. And it gives you an idea about, like it says, lipid or oil deficiency, dry eyes, meibomian gland dysfunction, so you manage that. But that overlaps with aqueous, and obviously that falls within the mixed dry eye conditions. And for those who are computer users, make sure you take that in the history because they need to take breaks when they're working. No matter how much eye drops you give them, it's not going to get any better if they don't look away from the screen and blink. For those who want to read up on this, there is probably about 100 different types of dry eye products in the market. And it was a very interesting paper, where they compared whether one was better than the other. And they found that there's virtually no difference between the different products unless you're looking at, obviously, if somebody has got evaporative eye disease and you're giving them drops for aqueous deficient eye disease, then that makes a difference. But amongst the other eye drops, there's hardly anything. These are the different groups. Can I just ask how many people still use hypermelose eye drops? Show of hands? Come on, don't be shy. Right, again, when you go away from here, please throw that away because it doesn't work. And they will come back, you'll have to give them more. Hypermelose doesn't work. So that's this group here. These others, the most popular ones are hyaluronic acid because they are closest to body secretions and they stay in the eye longer. So that's the reason. And increasingly we are going away from preserved ones because again we are finding out the hard way the ill effects of preservatives. So that's the kind of choices. The other thing that really works well, particularly in meibomitis, is omega-3s. And there's enough evidence now in literature to say that those help. Again, this is a very short pathway which I find very useful of how to start your treatment. So for the mild ones, like I was saying, you can start with hyaluronic acid, the least concentrated one, and then you can go up in stages depending upon the severity of the condition. So what's the future? We have so far looked only at the aqueous component or the oily component. Nobody has looked at the mucus side of things. So this is in stage 3 trials now, which actually causes increased secretion of mucus. And platelet-rich plasma is for people who have this severe dry eye conditions. So that, again, is like a tear analog. And when you cut onions, how many people cry? So that is what is being done with this one. They're developing a stimulator which stimulates the nasal epithelium and thereby makes you cry. I found this very interesting pathway which was developed in Suffolk, where they were referring it to primary eye care tri service, which is the optom-led service, and again, obviously, to economize things. And if they couldn't get a result, then only the patient was referred on to the hospital. What I couldn't find out is their audit of how successful this was, but I thought it was interesting because that's the way things are going at the moment. So to summarize, dry eyes is a complex thing, but there are simple things that you can do to help the patient. And in extreme cases, obviously, hospital care is essential, but there are simple things which can help the patient both symptomatically and management-wise. And sometimes they might need supportive treatment, for which we're more than happy to give advice. That's all, folks. Thank you.